Okay, so hey guys, good evening. I hope that I am audible, visible to all of you. The audio, video both are fine. Yeah. So I think we are ready to start. Okay. So today we are going to talk about the orthopedic question, the recalls that you had 2 days back, in your exam. So I was not here in Delhi and I was, outside. So I was not able to do the recalls on the same day as always. So I have got the inputs from the students only, and based on the inputs, the questions and the options have been framed. And do correct me wherever you think, you feel like that there should be some more corrections. So yeah, I think if you just can tell me if everything is fine, then are we ready to start? What happened? The voice will be all right? Right now, I think the voice is okay. If you can please confirm. So I was just saying that, I don't know from where the voice was lost. So identify the given device. So you can see that there are 2 pins which are going onto the femur. There are 2 or 3 pins which are going into the tibia, and they are giving you the option of something like Elizaro fixator, which obviously it is not a Elizaro. You all know how the Elizaro looks like. Now we are left with 3 options. The spanning fixator. So I was just saying what is the meaning, the basic word of the meaning, the basic meaning of this word, sorry, spanning. Spanning is something which is like a bridge between 2 places, no, 2 connecting areas. So when there is a bridge, you know, it connects 2 sides, and then you have the water somewhere in between, like that. Similarly, when you are you know, having a fixator which is called spanning, it is connecting 2 things. It means it is being given for some injury which is there in between. So spanning fixators of these kinds are given when you have either a femoral injury here, or you can say the tibial injury, the spikes here, the fibular injury. So when there is a proximal, you know, tibial injury or the distal femoral injury, including the patellar part, so whenever there is something intra-articular to keep the joint area, to keep the bone distracted, we give this kind of traction, right? So this maintains the traction, this maintains the length of the limb from in between area. That's what for the spanning fixator is used, right? I hope you wouldn't have marked it wrong, because the picture of external fixator I have always shown you in the classroom, isn't it? So that is obviously the image file that have been circulated for you all. Image file has been with you all, you know, all the time. The external fixators, the Elizaro, the JES, LRS has been a previous year's MCQ. You all know about it, isn't it? So this is something you should be remembering. You should be applying some logic to answer it. I can understand you would have find it difficult, a little bit difficult, but yes, this is something which you have to remember. If you want me to show the picture of the fixator, the file that I have been sharing with you all the time, let me show that file also with you, right? So let me just share that file also with you. Yeah. So orthopedic images, this is the file which I am talking about, and you know that you all, I believe that you have been downloading that file. So this was your Elizaro. Oh, my bad, what happened? Just a moment. Yeah. So this is the file that I've been talking about. This is, you all know, this is a Elizaro fixator, right? This is available in as a, you know, free file in the DBMCI Premier group, in my Telegram group. It is already there. So this is Elizaro. This is what you call a JES, and this one is an old fixator, old MCQ, I must say, the LRS, the limb reconstruction system, right? So looking at this file, I do believe you would have marked it definitely, you know, correct the answer for this one. Okay. Now this was the second one. This was the second one from, obviously it's a very common question, and I am pretty much sure that you have marked it very correctly, and that was some injury, the nerve, they asked for the identify the nerve injury and the most common complication if this condition is left untreated, and X-ray was given to you, right? The X-ray was given to you. So I do believe that you have been able to mark it very correctly. I got a mixed kind of response. Do correct me if I'm wrong here. I got a mixed kind of response about the question that we had in the orthopedic part. Some said no sir, it was a injury, you know, to the radial head. Some said no sir, it was a injury to the lateral epicondyle only. So what I believe is that lateral epicondylar injuries, they are very you know, common in a child. We know that around the elbow, what are the most common injuries? Around the elbow, when you talk about the injuries, you have the most common injury around the elbow. You know that it's fracture supracondylar humerus, right? And in supracondylar humerus, you know that the most commonly involved nerve is anterior interosseous nerve, and the most common problem, the deformity that you see, is cubitus varus. And that varus is because of what issue? This varus is because of the malunion, isn't it? That's because of malunion. And why the supracondylars always go into malunion? Because being the cancellous part, because being the metaphyseal area, highly vascular areas, soft areas, so they always unite, you know. So they have most common complication of getting into the malunions. On the other hand, the second commonest injury around the elbow in any of the child, it is the fracture lateral condyle of the lateral condyle of the humerus. So when you talk about the fracture lateral condyle of the humerus, you know that the most commonest injury, the nerve injury that can happen is usually a ulnar nerve, isn't it? But that's not a instant injury. It's a tardy, it's a late stage injury. So that's tardy ulnar nerve palsy. That's a tardy ulnar nerve palsy, right? And tardy ulnar nerve palsy, you know that the lateral epicondyle, it is also known as what? The fracture of necessity, isn't it? And why we call it a fracture of necessity? Because these injuries are supposed to be treated by surgical methods all the time. And what they are saying, what is the most common complication if it is left untreated? You know that if you don't treat the fracture of necessity, what will be the complication? You know, you can easily answer it. That is non-union. So this basically causes a late involvement of the ulnar nerve, damage to the ulnar nerve, which ideally should have been called a tardy ulnar nerve palsy, and non-union, obviously yes. So option C goes with it. And you have all written in your notes, because this is a very, very common topic. It's a very, very common, content that you have been writing all the time, you have been able to understand all the time in your classroom. The two most commonest injuries, right? The two most commonest injuries, the fracture supracondylar humerus and the lateral condylar humeral injury, right? So they asked about supracondylar fracture was given, okay, and they asked about the complication. Okay, Harsha, so you are saying that fracture supracondylar was also one of the option given. I am taking the point. So if that supracondylar was given, then option should have been AIN and the cubitus varus. Okay, then the option should have been cubitus varus. But here in the options that have been given by you guys to me, the AIN or the cubitus varus was actually not mentioned over there, isn't it? So I would go with the option C again, only damage to the late involvement of the ulnar nerve, basically the tardy ulnar nerve, and the non-union, which should be the complication, right? So I would go with the option number C we have mentioned over here. Okay, so what was the next one? So very common content of your notes that you have written. Bone fracture after 2 days came with dyspnea and breathing difficulty, which is due to, come on, I am pretty much sure that you have been able to answer it again. So bone fracture after 2 days, I can understand this is like incomplete kind of language of the question, which has been framed by you guys. Some points are missing. So if there is a dyspnea, there is a breathing difficulty, that is showing you some sort of involvement of the respiratory system involvement, and they are saying that there is a bony injury, and this is happening after 2 days. So we know that after 2 days, fracture of a long bone usually is related to what kind of complication? So we know that the complication which is related, it is what you call as the fat embolism syndrome, isn't it? And the criteria, sir, it was radial head fracture, and option was delayed treatment will lead to one cubitus valgus with non-union. Okay. One option was lateral condyle fracture with cubitus valgus. So yeah, lateral condyle fracture, I have written it over. So on this particular question, so it is what you call the fat embolism, and fat embolism, as we have discussed all the time in the classroom, the GERD's criteria, when before this INI examination, the PGA exam had asked this question twice or thrice, continuously in every session before this INI started, when all the 4 premier institute, they merged together and they started taking the exam together. So GERD's, you have already mentioned like this, that the fat embolism syndrome usually affects the person after 24 to 72 hours of the injury, right? The emboli, the fat globule, the source of the fat globule is basically the marrow of the long bone. That is the reason why after any sort of injury, you are asked that you must stabilize the injury, stabilize the bone, which should not have much of the movement, because with the movement, the marrow, the bone, the blood will come out and it can be a part, it can go into the circulation, producing multiple issues. So GERD's criteria, which that has got major criteria and the minor criteria, which I am pretty much sure that the major criteria you must remember. The major criteria being a decrease in the partial pressure of the oxygen, involvement of the respiratory system, involvement of the central nervous system, and the hemorrhagic patches, the petechial hemorrhagic patches. These are basically the criteria, the major criteria for the GERDs. It was mentioned just in RTA. Okay, point taken. Bone fracture was not mentioned. It was taken an road traffic accident. Okay, and was it Monish? If it was a RTA, then was the question again mentioning that it was only after 2 days that he came to you with dyspnea and breathing difficulty? Is it so? Is it so? If it is like that, then again it goes more in favor of C. Rest of the things, the pulmonary hypertension, the thromboembolism, the air embolism, these are usually not a part of the orthopedic questionnaire where you are talking about a road traffic accident or the bony injury or the fracture after 2 days something is happening. So it is most likely going in favor of the fat embolism, and the criteria, the GERDS criteria, the major and the minor criteria, which is a non-specific kind of list. And I am also again I'm saying that this injury, this is something very, very important from the clinical point of view. When you receive the patient in your OPD, in your ward, you must be very, very watchful. As a part of the treatment also, we must know the treatment options when we talk about it, the supportive management and the definitive management. So definitive management has to be, that the heparins, the steroid, they are a part of definitive management of the fat embolism syndrome. We must be aware of it. And then we have the supportive management. So in this we have a long list: the fluid management, the urine output, the ventilatory support or the oxygen inhalation, fracture stabilization. These are all the part. Yeah. So this was about the fat embolism syndrome, from where you can have the questions again in any of the further examination, right? So GERDS is 1, management is 2, and obviously the clinical diagnosis is 3, from where you get the questions. So this is again from your notes only that you have mentioned. This is clinical thing that you might have seen in your clinical postings as well. In your wards, in your ICUs, you might be having these patients who come to you after polytrauma usually, right? Then you have this kind of, this one, the question, right? Again, very, very simple, the tumor picture that I have given you, that you have mentioned in your notes, right? In the tumors, when you talk about the tumor of the benign tumors, you have one tumor called chondroma, and you have already mentioned in your chondroma that chondroma is the most common tumor of the hand. It is a most common tumor of hand, isn't it? And when it occurs inside the bones of the hand, the phalanges basically, what do we call it? We call it enchondroma, right? So what they mentioned, a 40-year-old female presented with multiple swelling in the hand and wrist area. Following finding was seen on X-ray of the hand. What is the daily diagnosis? So here we can easily observe that little finger is showing some involvement. The little finger is showing some involvement of fusiform kind of swelling, you know that, right? So enchondromas are the most commonest tumor of the hand, the skeletal tumor of the hand, not the most common tumor of the hand. I'm saying it is a most common skeletal tumor of the hand. I'm not counting on the soft tissue, right? So multiple enchondromas, what do we call this? Multiple enchondroma. What do we call this? Multiple enchondromas. That's what you call as the Olier's disease. What is so important about the Olier's disease? That Olier's has an approximate chance of 30 to 35% conversion into malignancy, right? And what is the other syndromic association that we know with enchondromas? It is Maffucci syndrome. It is Maffucci syndrome. So what exactly is Maffucci? Maffucci is approximately, it has got 100% chances of conversion into malignancy. And what exactly is Maffucci? When the patient has the enchondroma with hemangioma. So enchondroma plus hemangioma, that's what Maffucci is, right? That's what Maffucci is. So enchondroma and the hemangioma. Okay, so I think you should have marked this one also very, very rightly, very, very correctly. It was a simple, tumor, the multiple swelling in the hand, and these are the only points that we always write in the notes. That is enchondroma, Maffucci, Olier's, right? And obviously the fourth option we always write is the treatment part. That is usually the curettage and the bone grafting. Okay, the hemangiomas, yeah, GB Shaw. It was not bone fracture, sir. Yeah, Abrar got that point. I have mentioned already. It was RTA, as has been told by, who told me that? Monish. Yeah, Monish already mentioned that. Okay, so this was not something to be marked wrong. Simple hand tumor, we only read one, that's enchondroma. Okay, so this question had a again mixed kind of response, where guys just told me that, okay sir, some says that it was an antenatal injury, some says that it was a direct question which was being like that a patient or a child is having multiple fractures of the long bones. Which of the following is the most possible diagnosis? Even if it is an antenatal USG, or if they say that the child presenting with multiple fracture, that was the other option given, that child presenting with multiple fractures of the long bone, which of the following is most possible diagnosis? So obviously we read in orthopedics, we have this as one of the most important topic, which is actually a skeletal dysplasia, isn't it? That's a skeletal dysplasia which is genetically transmitted. Most often it can be like dominant, it can be recessive as well. So here we know that what is defective in osteogenesis imperfecta? It is your type 1 procollagen. You have marked in your notes again, isn't it? You have marked in your notes, that is type 1 procollagen. And the most important feature that I always explain, you have mentioned again in your notes, that when you are talking about a child with a multiple bony fracture, recurrent fractures and multiple fractures, it was antenatal. Okay, so point taken, it was antenatal only, right? So point is taken. Thanks, vice versa. Same question was given. Okay guys, thank you. So I've always told you that when you're talking about a child who is having multiple fractures, then one differential should always come to your mind, and that's battered baby syndrome. That's battered baby syndrome, right? That should be battered baby syndrome, isn't it? And what is the most commonest difference you will see in osteogenesis imperfecta? Usually these are the lower limb bones which are involved. It is the usually lower limb bones which are involved. Most commonly which bone? Most commonly the femur. Most commonly the femur. And in battered baby syndrome, basically the most commonly injured bone, the fractured bone seen is humerus. And what kind of injury we usually see? The spiral kind of fracture. Why spiral kind of fracture? You abuse, when you see a child who has been abused, the whole hand has been held and twisted. So humerus usually get an injury. Right, so upper limb, lower limb, that's the most common, kind of problem that you can see in these childrens, right? Next one, this was again, okay, sequence has been up and down. So next question was, a child after falling over left shoulder had pain over shoulder. Then he maintained his elbow in flexion while supporting by the other hand. So this was some kind of question given, right? I got a mixed review. Sir, injury can be scapula, injury can be humerus, injury can be like, clavicle, injury can be like multiple contusions. Some people told me that in the question there was a mention of multiple contusions on the chest as well. Is it true? Multiple contusion on chest. So that was also mentioned. If some of you can, battered baby obviously will be after birth only. I just told you for a theoretical purpose. When you receive a child in your OPD, that is what I said. When you receive a child in your OPD, then how to differentiate between battered baby and the osteogenesis. Obviously, when it is antenatal, how it can be battered baby? That's a logical thing, no? I was just saying, So it was basically, the answer should always be clavicle, because we know that the most commonest bone injured overall, if you talk about an overall injury, the most commonest, this is what you write down, this is what you mention in your notes in the pediatric trauma, isn't it? So most common fracture which is seen in a child, it is most common fracture I'm talking about in a child overall. Most common fracture in a child overall, it is the distal end of radius, isn't it? That's distal end of radius, which is followed by both bone forearm. This is the most common injury that you see overall. But yes, out of this scenario, the shoulder area, the most commonest injury that you see in a child, it is the clavicle area. It is the clavicle area, right? So scapula cannot be, scapular injuries are least common out of the humerus, clavicle, scapula. Scapular injuries are least common, though it can be humeral injury, agreed. But in that case, again, it needs more of a violence, more of a trauma. That is a possibility. But when we talk about the clavicle and the humerus, it has to be always the clavicle, which, has the most common incidences of injury in a child. Sir, because of clavicle lateral segment goes down because of gravity, so child is holding elbow. That's true. Yes, contusion is present. So I have taken this point. Yes. So because of gravity, obviously there is an injury to the clavicle. There can be injury to the humeral part. The shaft will also sag down. Clavicle injury, it will also sag down again. But the point is, more common injury out of humerus or the clavicle, which we should ideally mark, is clavicle only. And that's why you would have definitely marked clavicle. Humeral injuries, less common than the clavicle injuries. Okay. Next was again a question which was asked as a, you can say, integrated pattern of the pathology and the orthopedics part. So male child was brought with previous history of URTI, headache, currently having fever, fatigue, pain on walking, for which USD, and joint fluid aspiration. So basically they are trying to say that some joint is affected, right? They are trying to say that the joint fluid is there, right? And antibiotics were given for that. Peripheral smear shows something like this. What organism do you think you are going to aspirate? So basically, when you're talking about a joint fluid or a bone is getting affected, we know that it is being the septic arthritis, isn't it? the septic arthritis, or some of the student told me that some part of the bone was also involved, which I am not sure whether the bone was involved or no. But yes, joint fluid has been aspirated and antibiotic have been started, isn't it? Full was on shoulder. Okay. So GB Shaw, that is what has been mentioned over here, the falling on left shoulder, right? I haven't mentioned that it was an outstretched hand. Okay, so here you can see, what do you observe here? The kind of cells which are visible here, they are like sickle cells, no? Sickle cell, the organism, the patient who is suffering from sickle cell anemia, they are usually getting an infection by which organism? These are by salmonella only. So I don't know whether it was only septic arthritis or some bony involvement was also given, but the point is that they have clearly mentioned over here that joint fluid aspiration has been done. So when you are doing the joint fluid aspiration, sickle cell kind of picture, it has to be salmonella, right? That has to be your salmonella only. Okay, so this is the concept from your topic of osteomyelitis that you have been writing in your notes, the osteomyelitis, isn't it? The few organisms, the overall most common organism remains your staph, overall the most commonest, right? But when it comes specifically, they are asking you about the sickle cell disorder, then it has to go in favor of the salmonella only. Okay, bone involvement was there, right? So joint fluid, bone was involved, it was given as lytic lesion of lower end of femur. Oh great, you have corrected the question then. So it was you are saying that bone involvement, lytic lesion on lower end of the femur, a lytic lesion on lower end of femur. So when you are talking about the bone itself now, you know that we are talking about what? The osteomyelitis. So it was not septic arthritis, it was going in favor of osteomyelitis only. And sir, question 2 is non-union common in metaphyseal fracture because metaphyseal has rich blood supply. Okay. No, Anirban, in the second question we discussed that metaphysis has rich blood supply, it is a soft area, cancellous area, that's why it usually unites. Same thing, same picture is with the Colles fracture as well, the fracture at the distal end of radius at its cortico-cancellous junction, right? So that was the answer. So this is, guys, from your notes of osteomyelitis, that you always write down the sequence, the organism which are involving. So here only thing was that instead of asking it theoretically, they have given you the peripheral smear. You have to see the organism here, the design of the cell here, and you have to find out which organism can lead to the infection in this particular patient. Okay, so that was your next one. Then we had another one, a typical kind of clinical scenario question. Which will be the ideal treatment for a distal fibular? Okay, my bad. Just basically, I was told that this was a ideal treatment for a distal fibular fracture. Sharp ends at the fracture site, soft tissue swelling was seen. So as per the inputs that I have got, this was a closed fracture, isn't it? This was a closed fracture, it was not open one. Do you all agree with that? This was a closed fracture, and there was a the fracture was involving the distal tibia as well as the fibula as well. So there was a fracture line like that, there was a fracture line like that. Okay, so distal tibia and fibula, they were injured, they were slightly displaced as well. Okay, that was mentioned. Okay, so they said what will be the management for this patient? Analgesic, close reduction, cast. Yeah, that should be the ideal treatment, that's not a problem, but the question is saying that it was, as I got, closed fracture and these were displaced. Am I right? This was a closed fracture and this was a displaced fracture. Am I right on that? Distal ulnar or distal fibular fracture? So what do you say? Was it a distal ulnar? Zakaria Ahmed is saying, Zakaria Ahmed. Was it distal fibular and tibia fracture only? Was it only fibula or was it tibia as well? What do you suggest? What do you suggest? Distal bone. So basically what I mean to say is, when it is a closed fracture, when it is a displaced fracture, whenever the patient comes to you with lot of swelling, what is the first thing you are going to see? Neurological assessment is of importance. Analgesia, yes, that is required, no doubt about it. But point is, what is the emergency? The pain or the injury or compression of the neurovascular structures? Obviously, it has to be neurological assessment at first, right? So go for the neurological assessment, either B or C. After that, painkillers, yeah, you can give the painkiller, but the point is, if you give the painkiller at this point of time, yeah, it should ideally be given, but will it work? Not much, because the pain is because of the displacements. The pain is because of the soft tissue, edema, the compression, and obviously the fracture. So giving analgesia might help, may not help, but my point is, when neurological assessment has been done, when there is a displaced injury, when there is a swelling, I would like to first monitor my patient for the neurological status. So I would like to go for the close reduction and then check against for the neurological assessment, and then you can give the NLGC and cast, and all these things are going to work. So I think option C goes more in favor of what is being done in a normal case scenario where I am more worried about the neurovascular compromise. Pain will always be there, can be because of the fractures, can be because of soft tissue edema, stretching of the skin, bone impinging the skin, anything can be reason of pain. But once I reduce the bone, then obviously the painkillers are more likely to work or be effective in the patient, right? It was lower 1/3 of fibular fracture with fracture of medial malleolus. Okay, thank you Anirban for the correction. Yeah, Varis has also told me the lower 1/3, you are saying lower 1/3 of fibula. You are saying it was lower 1/3 of fibula with what injury? It was fracture of medial malleolus. Okay, okay. So yeah, so close reduction, this note you will find in your section of eGurukul notes where you are writing about the basics of trauma, what all treatment options we have available for us in different cases of the injuries. Immobilization only, close reduction and immobilization. So you'll find that whenever you have a displaced fracture, whenever you have a closed fracture, yes, obviously you have to go for a close reduction. Agreed. Neurological assessment always remains of utmost importance. Okay, why not D? Analgesia. Why? I told you, no, Ronak, if there was involvement of lateral malleolus as well, so lower 1/3 of fibula becomes your lateral malleolus, no? If you give the painkillers, you are just giving it a blanket cover for the, you are not talking about the reason of pain. That is why we want to first talk about why the pain started basically, right? Why the pain started. That's why we talked about. Okay, Ronak, I hope you got the point. Now, this is another question. This picture was supposed to be in the previous question. Ignore that picture. But I think this was some confusion by some student where they say that Galazi was given and all, which I think it was not there. So these were the questions. Do let me know, guys, if I missed out any question. These were the 8 questions which I got as a recall. So I hope that you have been able to mark all of them correctly. It was not tough. It was from all the routine patients that you see. It is from normal OPDs or the ortho, ward, your own notes. Okay, and if you have been writing your own notes yourself, you know that these were not difficult, right? Applying some logics. We have been discussing all the time that in exam there will be no question which you have to read from some extraordinary, journals or from the extraordinary references. These are all the simple things that you see every day around yourself in your clinical postings. Okay, so these are all the questions. If you missed out any, obviously reach out to me for in your Telegram groups. Okay, and reach out to me for any kind of other academic assistance if you can provide from end of DBMCI or from my end. Okay, so these were the questionnaires that these were the questionnaires, and I'm pretty much sure that you have been able to mark them correctly, right? So just let's hope that result goes very good as expected, and I'm pretty much sure that you are going to rock, right? So my bestest wishes for the result, guys. Just waiting to hear from you very soon. Okay, until then, just enjoy, just utilize these days with your family, with your friends, go on a short vacation and do whatever you want to do in your life, right? This time is not going to come back. Once the result is out, again the life resumes and you have to go back to the track, the college, the patient, and so on. Okay, so thank you so much for being a part of the session. All the very best. Thank you.